Hello, friends, and welcome to the Global Health Unfiltered podcast, the podcast about the unspoken realities of global health in Africa and the world. I am Ulrich Sitnik Amunye, your host today, and I'm here with my co host, Desmond Jumbam. Hello, Desmond.
Hey, Ulrich.
All right, so on this episode, we welcome back Dr. Emmanuella Amoako. Dr. Amoako is a consultant pediatric oncologist at Cape Coast Teaching Hospital, and she's also an American Society of Clinical Oncology IDEA laureate. Doubles as the head of clinical affairs at Yemachi Biotech, and she is a Dean Scholar at Harvard Medical School, where she's pursuing an MSc in bioethics. She's a strong advocate for childhood cancer and has authored numerous storybooks for children, as well as articles promoting increased access to life saving diagnostics and therapies. And importantly, I think all of you would know that she's a co founder of the Global Health Unfiltered podcast. And in this episode, we will dive deeper into her missions. One, to promote early childhood cancer detection with the help of community parent navigators, and to build the first dedicated pediatric oncology unit at the Cape Coast Teaching Hospital. Welcome, Ella.
Thank you. Thank you for having me.
It's a pleasure. Since your last appearance, so much has happened. So we're going to try and cover as much as we can. So first of all, congratulations on your six-figure grant for the Compass project. So can you tell us a little bit more about the Compass project?
Oh, thank you. Thank you very much. When you were reading everything you were talking about, I'm like, oh, is that me? I'm glad it's me. Yeah. So thanks again for making this possible. About Compass, which stands for Community Parents Navigating Childhood Cancer. It's an idea that sort of came up after Christmas party that we had for our survivors at the Cape Coast Teaching Hospital. So last year, every end of year, we sort of have a Christmas party for these survivors. And last year, when we had the Christmas party, we're just chatting to these parents to see how best to increase access, childhood cancer access in remote facilities. I must mention that even though I'm at the Cape Coast Teaching Hospital, most of my patients come from the western parts of Ghana and the western north, which is about 4 to 5 hours away from the Cape Coast Teaching Hospital. And so most of the survivors came from these places. And I was wondering why they had quite a number of them coming from that place and how we could improve access to those people. And it just dawned on me that out of 2 of my survivor parents who were attending this party, 2 of them had referred 6 children that they had seen in their communities to the Cape Coast Teaching Hospital, and 6 out of 6 were actually positive for childhood cancers. And so it clicked that if someone had a lived experience and they had a child that they could show as their medal of honor, for lack of a better word, and they could talk to people in their community, it might be more effective than having the healthcare workers go to talk to people, because I feel like people would listen to someone with a lived experience who understands the culture that exists in that society, also reducing the stigma that comes with a diagnosis of childhood cancers. So we just sat and was like, well, this is something we could do. What if we empowered these parents, number one, trained them, armed them with material that they could educate others in their communities, number one, and also tell their lived experience, train them to identify early warning signs of childhood cancers, and then refer them to a hospital where the children would be able to get treatment. And so there was a call for grants by the Sanofi Foundation, My Child Matters. And so my team and I put in this idea, but we sort of tweaked it a little bit. So we are going to train these parents whose children had completed treatment, number one. We're going to train healthcare workers at the district level, right? Number two. And then we're going to prepare the major hospitals, which for starters is the Kolebu Teaching Hospital and the Cape Coast Teaching Hospital, to receive these patients. So all of this will be connected together with an app, right? So the parents have a part of the app facing them where they take the initial details of the person, very little details, name, age, phone number. And phone number is very important because you want to be able to reach them. and if possible, take a picture of whatever they think they're suspecting as cancer. And then the whole idea is for the healthcare facilities to be mapped around the navigator, that parent navigator. And so on the app, they are able to refer to district facility around that area, knowing that those healthcare workers would also be armed with early diagnostic knowledge, right? And because they are healthcare workers, you're hoping that they'll be able to triage to see those that might be cancer and those that might not be cancer. And so they receive that information, and then that child's name and information comes to them. Within 24 hours, if the child has not appeared, they are calling, they are looking, because also the location where the child is picked up from is geotagged. They should be able to find the child. And then when they see there's a checklist which confirms whether the suspicion of childhood cancer is really high or not. And then from there, they are able to refer to a teaching hospital where the child can get treatment. So we are hoping to pilot in 2 regions for starters, and then expand beyond these 2 regions to the whole of Ghana.
That sounds like a potentially very impactful project. And I must say that, it's amazing hearing about this project. Also because Ulrich and I have known you for a very long time, and we know how passionate you are about the little ones with cancer. And so it's really an honor having you to talk about this particular project that you're fostering, and even more important to hear about how you're engaging the caregivers who, they are there with their patients, with their children. They know how heartbreaking it is to go through that process. So you're really empowering them and supporting them to help others. Can you give us an idea of other caregivers, parents that you've worked with in the past who are really helping based on their own experience to address early detection of childhood cancer in Ghana?
Yeah, it is quite interesting. As you mentioned, that some of these parents are going through it, right? Through and through. They have children that have been diagnosed with cancers. Some of them have even lost their children to cancers. But it's very, very interesting to see how everybody is willing to put their hand to the plow to make sure that other people don't go through what they went through. And I have so many examples of many parents who have reached out. As I mentioned, 2 of the survivors who came for the Christmas party had seen parents and children in their community, and the first thing they thought was to call and say, I saw this, I want to help them, can they come? And what had happened was, when they came and the diagnosis of cancer was made, when they went back to their communities, what those parents did was help them navigate, like call them, okay, you're due your appointment, right? So then they are reducing abandonment, not just the early diagnosis, but they are also reducing abandonment. And then we have parents who, even though have lost their children to this catastrophic disease, have had foundations that would help other parents not to go through what they went through. So foundations exist in Ghana currently, owned by parents who lost their children to childhood cancers, that educates people on early warning signs of childhood cancers, people that are coming to the hospital to volunteer during oncology oncology clinics to help these children go through their diagnosis with more ease than they went through. So I must say that even though most of these parents have been through so much, they are ready to help the next parents not to go through what they went.
Thank you. And maybe, Ulrich, before you go, I want to ask Ella if we can take a step back. And it's true that childhood cancers happen all over the world, but the realities are not the same for every child in the world, depending on where you're born, right? Can you paint us a picture of what that looks like for a child who is, diagnosed with cancer in the US, for example, versus in Ghana? What are the options? What are the challenges that they go through? What are the likely survival rates and chances of getting treatment?
Right. It's like that you brought this up because it's actually it's important to paint the picture so that people really understand why all of this makes sense. Like someone would say, well, it's childhood cancer. Everybody knows about childhood cancer, so they should be fine. You see pictures of bald children on websites and you see cure rates are high. Unfortunately, it's not the same for children in low and middle income countries. We globally we expect about 400,000 children to have cancer before their 15th birthday. Unfortunately, the burden is quite high in low and middle income countries. So about 20% of those cases are diagnosed in high income countries, and 80% of those cases are diagnosed in low and middle income countries. However, when it comes to survivor, 80% of survivors occur in high income countries and as low as 20% in low and middle income countries, and in some countries as low as 10%. And so when a child is maybe has cancer in places like the US or the UK, there are systems that exist that they get the care as soon as possible. However, for a child in Ghana, for example, they sort of have symptoms of cancer very early on. They go to maybe a pharmacy. Let's say it presents with joint pain. They go to a pharmacy. They are given some paracetamol. They go back home. They go back to the pharmacy, given some antibiotics. They decide to go to the hospital. Let's say it's a very remote hospital where maybe the staff don't understand what childhood cancer is, or there's limited diagnostic capacity. And so they are treating for malaria that never goes away. The parents at that point may say, okay, I've tried the healthcare service and it didn't work. So maybe it's spiritual, right? I mean, we're African, so it has to be spiritual. They go back. They probably go to church, they probably go to a herbalist, they probably go to a traditionalist and try and get some treatment. It doesn't work. They sort of find their way back into the healthcare system. Fortunately, by the time they arrive, it's quite late. It also means that advanced disease also means that you're using more treatment than you would use when they present in any stage. More treatment also means that they are going to be suppressed. Their immune system is going to be suppressed. That means that there's more infections. That means there's more money that you have to spend on antibiotics. That also means that they might die from toxic deaths rather than the cancer itself. So it's an interesting picture that we paint here, right? In a high income country, a child is seen, you suspect, you can do a CT scan, you can do a bone marrow, you can do all of these in a space of one day. However, over here, because most of these things have to be paid out of pocket, even when you suspect, you tell the parent or caregiver, there has to be some fundraising that has to be done before you even get a diagnosis. And in some settings, even getting a histological diagnosis to confirm it's very difficult. So these are the realities that we face. The other thing is the treatment centers might be very, very far from where the patient lives. So even though they receive their treatment, they have to travel maybe 5 hours, maybe 9 hours back to where they live. If they have to do that journey all the time, to the parent, it doesn't make sense. Once they see that the child is looking better, they assume that it's fine, and then they abandon treatment. This means that the disease is going to recur, and this means that we're going to lose that child at a certain point in time. So it's I don't know. It's a non-ending cycle. It continues from the point of diagnosis to the point of treatment, and even during treatment, retaining them sometimes is very difficult.
Yeah, it's quite interesting that, especially in knowing you see all these challenges, but that's never stopped you from coming up with potential solutions to those challenges and keep going after innovations or finding ways to make sure that the lives of the patients and their families are better. And it can, for some people, feel very demoralizing, I'd say. But I think what is also exciting when you are working in a space like this one, despite the challenges, is you actually see a return in terms of the appreciation from the patients, the appreciation from the families, because like you said, it's like a wave that never stops. It's always something. And to see people who are ready to step out there and advocate for them, it's always a good thing. So I wonder if there is a similar pattern of challenges that has painted itself ever since you launched Compass, and what are some solutions you've come up with?
Since we launched Compass on the 7th of August, thank you for highlighting that. I think for me, the major challenge has been the major challenge has been forex exchange rates, which is supposed to be good for the economy. Honestly, it's really good, and it's very impressive to see that our country, Ghana, has been able to strengthen its currency. However, at the point of application, everything was calculated at a certain figure at a certain rate. And at the time when the grant sort of dropped, it dropped at a time where the city was at its strongest. This means that you're losing so much money. And I think for so far, what we've tried to do as a team is to sort of build it up gradually, working around how to get the same impact with maybe working around the scope. And that's what we are trying to do. So taking it a step at a time, but also going back to talk to the funders to understand exactly what Forex exchange means in this setting when it comes to grants and the ability to carry on the work that you have promised to carry on. The other thing I think from the very beginning that has been quite challenging was to bring all stakeholders on board. Now, everybody is doing everything and you need to sort of bring them. But what the team and I have done so far is to go to each office and sort of tell them how important this is, and how really, if we have early detection, it means that children would be less sick. It means we are going to have a lot more survivors here. One of the other challenges that I envision, and honestly, I don't, well, I think I'm trying to create a solution for it, is the fact that we are going to find a lot more children, but the hospitals that are going to hold them might not have all the capacity. In Cape Coast Teaching Hospital, I literally have a 2-bed facility dedicated to children with cancer. Now, if I'm going to see, I don't know, when we started the Cape Coast Teaching Hospital Shared Care Center for pediatric oncology, in the first year of operations, we saw about 47 to 49 patients. Now, I can't use a 2-bed setting to hold these children who would come, because you're having people who are going to advocate. It means that you're going to pick a lot more children. Even the Kolebu Teaching Hospital, which is a comprehensive center for childhood cancers, doesn't have the capacity to handle all the cases that we might unveil from this. The solution would be to have a bigger center at the Cape Coast Teaching Hospital, a bigger center at the Kolebu Teaching Hospital. And I'm trying to find a solution for this, but I know it's not like short term. I know it's not going to be easy. And I think we can talk about how that is going when you're ready.
Yeah, absolutely. We can get into that. And I know that a lot of your passions are motivated by the patient encounters that you had, in the first season. You talked about 2 patients born in different parts of the world with the same diagnostics and very different outcomes. This next endeavor that you have has been motivated by a 14-year-old boy from Tarkwa. Can you tell us about that boy and how it has motivated your next endeavor into pediatric oncology in Ghana?
All right. So this was 2019, fresh out of residency. I was feeling myself, So back in Cape Coast, this 14-year-old boy comes in from Takwa. Takwa is about 4 or 5 hours by bus to Cape Coast, right? That means it's about 9 hours to Kolebu Teaching Hospital. Now, this child comes from Takwa. Mind you, they've gone to another facility before coming to the Cape Coast Teaching Hospital. So they'd been to like a primary healthcare facility, gone to a district hospital, and then finally transferred to the only teaching hospital that serves these 3 regions. So the western the Western North, and the Central region. So they were referred to the Cape Coast Teaching Hospital. Now, at the Cape Coast Teaching Hospital at the time, we were not treating children with cancers. So this child comes with a lymphoma, and lymphoma is one of those diagnoses where the children have what we call, they are at risk of what we call tumor lysis syndrome. So tumor lysis syndrome is simply the tumor is breaking as quickly as it is, or it's turning over as quickly. It also means that it's shedding a lot of DNA, which breaks down to, say, uric acid and other components, and then it has to go to your kidney to be flushed out. But because the turnover is quite high, the kidneys are not able to function as they should function, right? So then these children have like different issues going on: electrolyte imbalance, high uric acids, they can have seizures, they can go into acute kidney failure, right? And so this child literally presented with that. And at the time we saw him, he had acute kidney injury. And the first thing I said, I'm like, well, we can't treat this here. And the first thing I'm like, no, he has to go to Korle Bu. And so I call my professor at Korle Bu and I'm like, Prof, I'm going to refer this child to you because I can't treat, we don't treat cancers, childhood cancers at the Cape Coast Teaching Hospital. And her first thing is, this child is not going to make the journey. So there's no point referring, but you can do something. You can try and do something. I'm like, nah, I'm not equipped. There's not this, there's not that. I mean, of course, you always have excuses. Excuses are easy to give. And she's like, no, you have to try. But what was really helpful at the time, and I would say this for the Cape Coast Teaching Hospital, is how the ease at which you could actually get some of these things done. So this child needed dialysis, and the team at the dialysis unit was ready to have the child and dialyze him, right? The child needed some chemotherapy. We're lucky that the hospital was already treating patients with breast cancer, and some of the drugs that you use for breast cancers are the same drugs that you'd use for this child who had a lymphoma. So we're able to talk to the pharmacist to sort of mix this medication. Everybody on the team was willing to help because this was a child that we were watching go away. And so we were able to take him to dialysis. We were able to start some chemotherapy. We were able to hydrate him. And then he was stable. So I'm like, yay, we did it. Now we're going to refer him to Korle Bu. And I called my friend. I'm like, so now he's stable. We're going to refer him to Korle Bu. And she's like, no, once you were able to do the difficult part, you can do the easy part. And the easy part would be just the continuation. Number one, he stays in Takwa. If he has to come to Korle Bu every 3 weeks, that's a 9-hour journey. We don't think he's going to sort of stay in the treatment. Number two, it's something you can do. You've done the difficult part, so go ahead. And that's really pushed me to be able to start treatment for this little boy in Cape Coast. And they were so grateful. They were able to go home, which was far hours away, and come when they needed treatment. And I must say, so many years later, so this was 6 years later, he's still alive and well, right? And so you think about that and you're like, okay, you need a center here because not everybody is going to go to Accra. Not everybody is going to make that journey. 9-hour journey to Accra. And even if they went, the likelihood of abandoning treatment is quite high because it's quite a distance for them to go there. So that's little boy, well, not so little, 14-year-old, who is now like very tall and taller than me. But that's stuck with me and also made me know that it's important to have something for the people in these 3 regions to be able to access treatment to childhood cancers.
Thanks. I can't help but think about this whole 9-hour journey to get to Accra. I mean, you put it into relative terms, and you could literally get on a commercial flight from Accra to London, and you would get to London before this child got to Accra. That's really unfortunate. And it's a good thing you're mentioning that, getting access to care closer to home for these children with childhood cancers is a priority. But as you mentioned earlier, you said there's a need to expand the pediatric oncology unit at Cape Coast Teaching Hospital. So can you tell us what the current situation is? You mentioned 2 beds, right? But besides the 2 beds, and how do you intend to increase this capacity?
Right. So currently, as I mentioned, 2 beds dedicated to pediatric oncology patients. So it's a room that we sort of had to make shift to be able to fit these children there. However, you don't see 2 patients at a time most of the time. So they overflow into the main ward where there are other children who have everything. I mean, it's a pediatric ward, so you have children who have all sorts of illnesses. One of the ones that are very common would be maybe a pneumonia, a really bad pneumonia, or like an infectious disease. And you have this child who is receiving chemotherapy or has received chemotherapy and has come in with low counts. And sometimes you have to place them next to this other child that might have like a really bad pneumonia or some other sort of infectious disease. And we know that with the kind of treatments that we give to the children who have cancer, they're at risk of catching other diseases from other people. So currently that's what it is. So there's a 2-bed that is dedicated, but then there's always overflowing into the main ward. What we are hoping to do is to have a whole unit for children with cancer. The hope is to have a 24-bed unit for the children with cancer. So 10-bed for daycare. So daycare, those outpatient cases that will just come and receive their chemotherapy, and 14 lay-in wards for these children. But it's a unit that will be equipped with a pharmacy, a playroom, counseling, everything. Like it's a one-stop shop for children with cancer. I must say that Cape Coast Teaching Hospital is able to provide us with pathology services. There's radiological services that exist. We have other members of the multidisciplinary team that are able to help when we need them. And then we're in direct contact with the team at the College Teaching Hospital, such that when there are cases that are beyond our control, there is a very timely way and a good way of referring them to care.
Right. Just going back, so you're going from 12, I think, to 24. That's a 12-fold increase in bed capacity. So I'll guess that it would require additional investment. For example, you probably need more doctors, more nurses, and other infrastructure besides what you have currently. So would is it am I right to guess that you are trying to increase this in a phased approach over time? And what will that look like practically?
Yeah, you're absolutely right. So what we've been doing stepwise, as you mentioned, we're training staff. So currently we've trained 4 pediatric oncology nurses. We have another pediatrician who is going to start her pediatric oncology fellowship. So that is not just a one woman work to do. We're also sending 2 more nurses for pediatric oncology training. That would make 6. Over time, we've noticed that there are other people that are showing interest in pediatric oncology, so we're going to bring all of them together. The other goal is to build this new unit. So it's 2 to 24. That's like, I don't know, 24. But we are hoping to build this whole unit. Thankfully, the hospital has provided us with the land. It's there. Anyone who wants to see it can come and see it. The land is there. We're hoping to build this unit using what you call this shipping containers. So a sustainable way of building this, a cheaper way of building this, and a quicker way of building it, because using shipping containers means that it can be prefabricated and then moved to the site. And building these will take shorter than it would if you use brick and mortar. So we've worked with stakeholders who that is their primary job, like building container buildings. And the architect that we're working with is actually one that built Children's Hospital in Accra using shipping containers. And you would never tell, right? And so we've worked with him. His team has been very gracious. We've also worked with an insurance company that is sort of helping to put like, okay, if this building is up, you're going to insure it to make sure that so and so and so we at least it's insured. Now we have to bring other stakeholders to the table. So we've been able to convince the hospital management that it's important to have this, and we have buy-in. That's how come we have the land. We're working with an NGO, the Viva Texan Foundation, and I must say that Viva Texan is a child that we lost to cancer, and her mother would stop at nothing to see that other parents don't go through what she went through. She had to make the journey from Cape Coast to Accra every single week when her child needed chemotherapy. So the child takes chemotherapy. She needs to drive on this road with this child who might be vomiting from Accra to Cape Coast. And it was a trip she had to do all the time. And even though she lost her child and she could say she didn't have to do anything, she doesn't want other mothers or other parents to go through what she went through. So we've worked with her so far, and she's supporting with the fundraising. And then we're working with the architect and then this insurance company. Right now, what we need is money. You need money to do this. And so what I'm doing right now is trying to crowdfund, but also hoping, or not hoping, I've actually started talking to other stakeholders that might help. Crowdfunding is not the easiest thing to do. My goodness, I thought it was. I honestly thought it was, but it's not. But yeah, so far that's what we're doing to achieve this dream.
Well, crowdfunding may not be easy, but it's definitely worth it. And your passion for this project and for children with cancer in Ghana definitely comes across as you speak. Sounds like you're doing the right things, and you have a lot of experience in this area. You've gotten the support from Cape Coast Teaching Hospital in terms of plan, in terms of additional support in the future when this is built. We are working with caregivers who have established foundations to raise funds and to raise awareness. And I can imagine that our listeners are listening to you and feeling just like me, like getting impassioned as well. So for our listeners, how can they support this initiative that you're leading to address pediatric cancers?
I always say nothing is too small. Every help counts. There's a GoFundMe link that's, I don't know where I would share it, but if we add it to our notes, they could click to donate. They could reach out to us on the Global Health Unfiltered podcast to donate items once this building is ready. Shipping line, if you have shipping containers that you're not using, please, we need them. You could donate anything, and when the center is ready, you could come and volunteer there. Once that center is up and running, it means that we are going to have so many other children. If you have to donate blood, you want to donate, that's absolutely fine. If you want to adopt a child to help them through treatment, that is absolutely wonderful. So nothing is too small, really, nothing. And we are ready to receive help from anybody, and any form of help is help. Help is help, I always say. And as for me, I'm a proud beggar, so I don't care how I get it. If I have to kneel down, I will, but we'll do anything that is right for the children.
Yeah, that's one thing that we'll notice about people who advocate for children. People like Ella, very passionate, they really do anything to make sure that children get. And Ulrich and I, we've seen this over the years. There are times when we'll get random midnight phone calls from Ella saying, "Do you know anybody who has this? Do you know, there's this child, they need blood, they need this," right? So can definitely vouch for the fact that, I will go to bat for these children. So what we'll do is we'll put the link to the GoFundMe in the show notes as mentioned. And then perhaps we'll also put a list of additional items that can be donated, and how you can contact Ella's team if you would like to support. So over to you, Ulrich.
Yeah, thanks, Des. One of the things I've always appreciated, besides the fact that we were born on the same day, is that your practice is really all encompassing, right? So we've seen you work on the advocacy side for the patients. That was with the storybooks. We've seen you now work through Compass on the parent side, patient side. I mean, when it comes to chronic diseases, when it comes to things like cancer, it's very easy for people to forget about those that are supporting the patients. Honestly, it's very easy, but it's anyone who's gone through that know it's not easy at all. It's not. And you feel that almost that guilt of saying how you feel because you're not the one with the condition. So it is really a laudable activity that you're, focusing, targeting this population, giving helping them give back by also helping other parents and then forming a community. But importantly, like we've mentioned, you also have a very active scientific career, research career, notably at Yamachi Biotech, where you're the head of clinical affairs, as we said in your introduction. So right now, you guys are pushing the limit with very exciting project, which we've spoken about in the past, the African Cancer Atlas, which aims to create the world's first comprehensive cancer genomic database focused on African populations. So can you give us maybe perhaps those updates that you can share and why this was so important?
Right. Yes, thank you. So the African Cancer Atlas is an initiative that hopes to sort of map the African genome, especially as the name is the African Cancer Atlas. Now the Global Cancer Atlas exists, but we know for certain that it's not as diverse as we hope it should be. Only about 2% of Africans are represented in many biobanks across the world. And so really most of the clinical trials or the drugs that are used in cancer treatments might not work the same for African patients. So mapping this genome really is building the foundation for a truly African cancer care, right? So it's like precise. And we know so well that because our populations are so genetically diverse, and I must say that the African genome is the most genetically diverse that exists in the world, but is the least represented in global research. There are many tests and treatments that don't work well. The arguments can be made that maybe our people present late, but I mean, some of these treatments are used in advanced stage diseases in people of other descents, and it works. But because studies have not really taken place here, and we don't contribute as much to the data that exists, this project, what we are going to do, would help understanding the blueprint of the African genome. And by doing this, we can improve diagnosis, we can tailor treatments specifically. So that's where you have your precision, and make sure that breakthroughs in cancer care are effective, not just for every other person, but people of African descent. So this atlas really is about equity, it's about precision, and it's about saving lives globally.
Thank you for the update on the Atlas project. And I know that, Yamachi has a different approach to addressing cancer care on the continent. But we do know that a lot of the cancer research that is done on the continent, a lot of it was probably funded by external entities like USAID and the National Institutes for Health here in the US. Have you noticed any changes, or how do you see the recent changes in cuts to USAID and National Institutes for Health affecting cancer research on the continent, and what opportunity does it present?
Yeah. And like that you brought this up, and we, I think even on the Global Health Unfiltered podcast, we've spoken about how most of these cuts are going to have really science in Africa, because science in Africa has really been funded by external funding, and even the direction, like choosing what to research on, has always been decided on by the funders, because I mean, you can only do what the one who gives you money tells you to do. I think really in the past few months, it has shaken things in the scientific space, especially with regards to cancer care. But I also think that it presents an opportunity for Africans to know that we need to fund this ourselves. And going forward, we can own that research, right? So it presents an opportunity to shift from donor-based research really to investment. So this really presents an opportunity for us to invest in our health system. What Yamachi has done over time is to sort of raise funds, private equity, venture capital funds, to sort of direct research such that the research does not depend on what the funder wants, right? And I think it presents us with an opportunity that biotech is actually, it's possible in this part of the world. We don't always have to rely on grant funding. Yeah, so it's terrible that it was abrupt and people are going to suffer. but it also presents a long-term opportunity for growth on the continent.
Yeah, I mean, you're making that point, and I seem to remember when we had Yao Pedeko sometime very early at the start of the Global Health Unfiltered podcast. He was making that case actually about the over reliance on governments. He wasn't just talking about foreign governments at the time, but it seems that he's been proven right with this current situation. And that really raises a lot of questions, but like you said, a lot of opportunities too. And it is honestly an opportunity that is a once in a lifetime, not only for institutions or organizations like Yemachi, but even for our patients, because I can't help but think that that puts institutions like Yemachi in a better position for negotiation as things are shifting. And you being a big advocate for your patients is definitely going to be something that you'll be pushing for to make sure that they actually benefit from the proceeds of all that investment. Yeah, I think that that is definitely something that needs to be said. But going back to your work, perhaps on a, let's say, day to day as head of clinical affairs, what does it look like?
Right. I would say it's a mix of both. You talk to someone today, they are very excited. You talk to someone tomorrow, they're a bit skeptical. This has opened my eye to the talent that exists on the continent. What's really what my work is to work with clinicians in various hospitals in various countries to make them understand the need for this research. And as I mentioned, a lot of people are very enthusiastic. However, you'd always have some people that are skeptical. Are you able to do it? Is this something that you're able to deliver? I think over time, people have worked with foreign collaborators, and it's easy to maybe collect samples and then ship abroad and have those results sent back to you. But it's also necessary to be able to do all this work on the continent, such as samples don't always just leave the continent to somewhere in a lab in US or Europe, and you really don't know at the end of the day what happens to those samples. But if you have that, and I think recently and in the previous episode, you spoke about sovereignty, data sovereignty. I think this project really is one that would guide and should guide the fact that Africans should own everything that they do. And the need for data sovereignty and not just shipping samples abroad and receiving results. But if you have everything being done on the continent by Africans for Africans, I think it's something that a lot of people should look forward to and should learn from. But working with clinicians and scientists across the continent has presented its challenges, but I must say that there are a lot of people that are willing to jump on it. And then we need to deal with the compliance in various countries, the many rules that exist. It's not the easiest thing to do, but it's something that we are working towards.
There's a common thread in all that you've said. The common thread I feel is ethics, bioethics, about the compliance, about making sure that there's equity, that things are done properly, but also making sure that it is not only for the individuals, it's for the common good. And when we're talking about ethics, it's really a difficult balance, right? And it's not a one size fits all. And that sort of segues into what we mentioned. And obviously, congratulations for your admission to the Masters of Science at Harvard Medical School in bioethics and with a Dean Scholarship nonetheless. So why would you, just before we round up, why bioethics and what do you hope to accomplish with that?
Right. Thank you. It's interesting. Sorry, I'm laughing because it's funny. I'm like, why am I doing all these things? I don't know why. But bioethics has always been, and as a clinician, especially working in this part of the world, it's always been something that you're faced with on a day-to-day basis. Like, what is equality versus equity? When you have one ventilator and 3 children that need a ventilator, how do you make that decision? But what really drove me finally to do bioethics, because it's something I've been putting aside for a really long time, but what really drove me finally to do it was not the everyday clinic work where we have to sort of make decisions on who deserves the oxygen when it's just one pot that exists. It was driven by all the work that we are doing at Yemachi, the genomic work. Now, again, because the African genome has not been fully studied, most of the results that come from the tests that we do, and this is not Yamachi, like even on the clinic side, we do for patients comes out as maybe variant of unknown significance. The question is, I mean, it's a variant of unknown significance because it's not been fully studied. And then one time you might have a genomic test that tends a poor prognosis for that patient, or one that means that they need to do a yearly MRI. And you're sitting there and you know that everything is out of pocket. How do you even tell this family that they need to do this? Do you need to communicate that result to them? Do you even need to test them? Like, what is the end goal of all of this? Because, yeah, it's interesting for a scientist. We want to understand, but then how does it affect to that one family, that one patient at the end of the day? So that was really what drove me to bioethics at the end of the day. And I had this one child who we had sent a sample abroad, and it came back to be a syndrome that, I mean, it got me excited as a clinician. I'm like, yeah, I thought about it. It means I was right. But then just when that joy about being a clinician settled down, I'm like, yay, it means he needs yearly MRIs. It means he needs this screening and that screening. It means he's at risk of cancers. But what are we going to do in this part of the world? How do I even tell the parents? Does it mean that it's a child that they would sort of close their eyes to because this child is going to cause them so and so? And so, I mean, at the end of the day, really, that was what drove me to bioethics. And I'll be happy if I'm able to answer the other questions of equity versus equality and justice and autonomy when a patient decides to, when you say the patient has autonomy, and they decide that you should make the decision for them. It's their autonomy, like it's their rights for them to decide who should make the decision. But as a clinician, you're like, nah, I don't want to make the decision. But the patient thinks they're okay for you to make the decision. I have a lot of questions to ask, and I'm hoping, I know I will not get all the answers, but I know it would potentially help me navigate some of these situations.
Yeah, I mean, for some of us, the nerds, having a lot of those questions asked, I can already see the stimulative conversations that will be happening in your lecture. I'm sure that your colleagues, your classmates, as well as your lecturers will really appreciate it. And when you said initially, when we mentioned the Masters of Science in Bioethics and why am I doing this, it made me think about the video of the lady who ran, I think it's a marathon. And then when she ended somewhere in the Olympic Games, then she said, I don't know who the heck I think I am. I don't know why I thought I could do this. It just, that's exactly what flashed in my mind. But we know that those are the kinds of things, like the best things are going to be had, through pain. And that's what we have right here in our context. All these challenges are what make the wins when you get them so much better, because everyone is having conversations about how there's only so much more we can discover in medicine. People say it's about errors of precision, rounding numbers, no big innovations or discoveries like the antibiotics and the rest. But I think Africa is still at that place. It's a place where, yes, it gets frustrating, but if you're working as a scientist, as an economist, anything, you literally can make that much of an impact and actually affect people's lives. So it's really interesting and inspiring to have all this conversation with you. Thank you so much for making the time to be with us today, Ella. And just as we're wrapping up, any final thoughts or reflections you'd like to share with our listeners?
Yeah. I would want to thank you. Today, I'm not saying I'm your co-host, but you know I'm your co-host. So, but I would be grateful if we all put our hands to help children, not only in Ghana, but in every part of the world. This project means a lot to me, and I would be grateful for the opportunity to be able to deliver good care to the children of Cape Coast, and not just Cape Coast, but the other regions that present to this facility. So thank you all for listening, and thank you for giving us your time.
Oh, thank you, Ella. And thank you to our wonderful listeners who have been with us since season one and who've been very patient and encouraging. We've seen all your messages. We regularly share them, whether it's on Twitter, on LinkedIn, or via email. We are very excited about the Africa Health News Weekly, which is a newsletter that goes out to those who are registered. If you're not registered yet, please, go on the website and register. We bring together, we collate some of the most interesting stories about healthcare, whether it is positive stories, negative stories, but the ones that you probably wouldn't hear about if you are usually at the World Health Assembly, the United Nations General Assembly, those ones that really help you get a better understanding of why we do this. Because every once in a while, it's easy to forget why we do this because we get lost in so many details. And we look forward to bringing you more episodes in the next coming weeks. Thank you very much for being with us once more. I will see you in the next episode. Ciao.